Good morning all. Today we are going to see about the condition tracheoesophageal fistula. So tracheoesophageal fistula is an abnormal connection between the trachea and the esophagus. So there is a connection, abnormal connection in the esophagus and then trachea. So next we are move on the incidence rate. It is occur in 1 in 3,500 birth. A slight male dominance. Premature TEF are generally not premature. So here the male children is more dominant than the female children, and then those are having birth less than 2,500 grams of birth, their children are prominently they have this incidence of the TEF commonly. And next we are more on the etiology. There's the two factors. First one is the congenital and next one is the acute. In congenital esophageal atresia associated with anomalies and then acute, malignant and benign. And next we are more on the what is the possible influence of this disease. So inheritable genetic factor, sporadic reports of twins babies. Those are twins babies, they may have the TEF and siblings, and then offspring of affected adult. Teratogenic stimuli. Teratogenics means that agent disturbs the development of the embryo of the fetus. Teratogens they may cause, but the defect in the children or teratogens may have. And the next environmental factors, hereditary, genetic factors. These are the factors that may cause the tetralogy phalate. So in next we are more on the classification of the tetralogy phalate. It will be classified in 5 types. And in type 1, proximal and the distal segment of the esophagus are blind. So here, distal part, esophagus or distal part and then proximal part are become end. There is no connection to the trachea. So here, this type is commonly seen in 3.2 to 7% of commonly we can see in this type of tracheoesophageal fistula. In type 2, there is a proximal segment of the esophagus open and then trachea by fistula. Distal segment is blind. So distal part of the esophagus is blind. Proximal part will be connected with the esophagus. So next we are on the type 3. In this type, so type 3 is proximal and distal segment of the esophagus are blind. There is no fistula or there is no connection in the trachea. So here the blind part in the esophagus, and this is commonly occurs in 3 to 7 to and next type 4, esophageal atresia with the fistula between the proximal and distal ends, trachea and esophagus. So it is occurs in 0.7 to 6% of cases. They are commonly affected in this type of esophageal atresia. And the next one is the type 5. Here, proximal and distal segment of esophagus open into the trachea by the fistula. No esophageal atresia, but sometimes refers to an H type of fistula occurs. So we can see in this picture itself, there is an proximal and distal segment of the esophagus open into the trachea, but there is no atresia, there is no abnormal, there is no fistula, but the connected in the fistula, connected by the fistula, it make a H shape fistula. So it is occur in 4.24% to 7% of cases diagnosed as this type of esophageal atresia. So next we move on I think you are familiar with these types of the esophageal atresia. Next we move on the pathophysiology. So here the baby with the tracheoesophageal fistula is unable to swallow effectively with the result of accumulated esophageal pouch and aspiration in the respiratory passage. Gastric secretion may regurgitate through the distal fistula. So once the distal, there is a hazardous, and then in some cases esophagus that connected with the trachea. So here the abdominal distance will be there because through the trachea air entering the lower esophagus through the fistula and pausing into the stomach during crying. Respiratory distress may develop due to the gastric distension and an elevation of the diaphragm. These are the this is all about the pathophysiology. And next we are more on the clinical manifestation. In clinical manifestation, intermittent get an unexplained cyanosis, laryngospasm, abdominal distension, violent response of baby, poor feeding, inability to pass catheter through the nose or mouth into the stomach. These are the clinical manifestation we can say. And then diagnostic evaluation. So complete assessment we have to do, and an ultrasound scanning technique we have to follow. X-ray of abdomen and chest, barium X-ray, electrocardiogram, and then echocardium. These are the investigation we have to done for these children. Those are having so immediate treatment. If they already we know about the what are the symptoms we get in the children's. So those are having these symptoms, we have to keep the babies in propping up position. So we have to keep the babies in 30 degree of angle to prevent the reflex of the gastric contents. And then we have to put the NG tube, hysterotomy, and then nothing by mouth, which means we have to keep the baby in NPU. And then to prevention of the dehydration, we have to provide IV fluids for the baby. So here we have to provide continuous IV fluid for the babies. In supportive therapy, we include the IV fluids, antibiotic, respiratory support, and then maintaining thermally neutral environment for the baby. And the next one is the surgery. Here we have to do the anastomosis surgery, hysterotomy surgery, circular esophageal surgery, cervical esophagotomy surgery. These are the surgical intervention for the tracheoesophageal fistula. Tracheoesophageal fistula. I hope that you all understand about the tracheoesophageal fistula. See you all in the next video. Thank you.